Welcome back to the deep dive. Today we are wading into waters that are quite literal. We were talking about the vital river that runs inside all of us.
That's a great way to put it. It sounds poetic, but honestly, it's clinically spot on.
We're looking at the fluids that keep us alive, the electrolytes that spark our nerves, and the very delicate balancing act that, if it goes wrong, can spell disaster faster than almost anything else in the body.
It really can.
We are diving into the vital balance, specifically dissecting Chapter 10 of that massive MedSurg text that I think everyone loves to hate.
Oh, absolutely. And I know for a lot of you listening right now, especially if you're a nursing student, Chapter 10 is the absolute boogeyman.
It's the chapter everyone dreads.
It really is.
Mhm.
Because it's not just biology.
Yeah.
It's chemistry, it's a bit of math, and it's physics all colliding at once. But here's the mission for this deep dive.
Okay.
We want to get you past just memorizing things. Anyone can make a flashcard that says sodium, 135 to 145. That's the easy part.
Right. Memorizing a number is one thing, but knowing what to do when that number is, say, 120, that's a whole different ballgame.
Exactly. We want to move you from memorization to what we call clinical intuition. It's about walking into a patient's room and realizing they're deteriorating before the monitors even start screaming at you.
Just from the little clues.
Just by looking at the furrow in their tongue or the veins in their neck. That's the goal.
I love that. So we're looking for the red flags, the safety alerts, and really the logic behind the numbers. So where do we start? Let's start with the landscape, the big picture.
Sounds good.
The text opens with a stat that I think most of us have heard, but I don't think we really visualize it. The 60% rule.
It's the foundational number. Roughly 60% of a typical adult's body weight is just fluid. It's just water.
So let's do the math on that for a second. If I weigh, say, 70 kilograms.
Then about 42 liters of you is water, which is, imagine 21 of those big 2-liter soda bottles.
Wow.
Now imagine strapping all of those to your body. That is what you are carrying around every single day.
That is a staggering amount of liquid. It's hard to even picture. But it's not just one big tank, right? It's not like we're just water balloons with legs.
No, and that's where it starts to get complex. It's all compartmentalized. You have the intracellular fluid, the ICF, and the extracellular fluid, the ECF.
Okay, so break those down for me. Who's the heavyweight here?
Oh, the ICF is the champ. By
Right.
far, 2/3 of all that water is sitting inside your trillions of cells. It's what keeps them plump and functioning. If you lose that, your cells literally shrivel up.
And the ECF.
That's the remaining third, everything outside the cells.
Okay, but the ECF is the part that we as nurses or clinicians, we interact with the most, isn't it? That's what we have access to.
Yes, 100%. Because the ECF is split again. You have the plasma, which is just the liquid part of your blood, and then you have the interstitial fluid.
Which is what exactly?
That's the stuff that's just bathing the outside of the cells, the sort of swampy environment they all live in.
Got it. Now, normally the body is a genius at keeping all this balanced. But there's a concept in this chapter that always trips people up. Third spacing.
Ah, yes. The black hole of fluids.
It sounds like something from science fiction. What is actually happening there?
So normally, fluid moves between useful places, right? Between the blood vessels and the cells. Third spacing is when that fluid moves into a space where it is totally useless to the body's circulation.
Like where? What's a classic example?
The abdominal cavity. You see it in the sites with liver failure patients, or the pleural space around the lungs, or even into the soft tissues after a really severe burn.
So walk me through the clinical picture here, because this sounds like a total paradox.
It is. It is a paradox. You can have a patient who is technically retaining a ton of fluid. They might have gained 10 pounds of water weight, but their blood pressure is tanking, and their heart rate is sky high.
Because the tank is empty, even though the warehouse is full.
That's a perfect analogy. The fluid is trapped behind a locked door. It's physically inside the patient, but it's not in the veins where it needs to be to keep the blood pressure up.
So you have to treat them for low volume, for hypovolemia.
Even though they look swollen and puffy, yes.
That is such a critical distinction for the students listening. You can't let the edema fool you into thinking they're hydrated.
Never.
Okay, so we've got these compartments. But the water doesn't just sit there, it's constantly moving. And to understand how, we have to talk about traffic control.
The transport mechanisms.
Osmosis and diffusion. Now, I feel like we all learned this in, 8th grade biology? But refresh us. What's the clinical difference?
The simplest way to think about it is this. Diffusion is the particles moving. Osmosis is the water moving.
Simple enough.
In diffusion, the little particles, the solutes, they want to spread out. If you drop food coloring in a glass of water, it spreads out from high concentration to low concentration until the whole glass is blue. That's diffusion.
And osmosis.
Osmosis is the water chasing the party. Water is drawn to where the concentration of particles is highest. It wants to dilute it. So it moves from an area of low solute concentration to high solute concentration.
Okay. And managing all this traffic requires some heavy machinery. The text spends a lot of time on the sodium-potassium pump.
The metabolic engine of the cell, it's so important.
Why is it such a big deal?
Because the body is absolutely desperate to keep sodium outside the cells and potassium inside the cells. But nature, diffusion, it wants to mix them up. It wants them to be even. So the cell has to constantly fight to keep them separated.
It's fighting against the current.
Constantly. This pump uses what's called active transport. It burns ATP, that's cellular energy, to physically grab sodium ions, throw them out of the cell, and then grab potassium ions and pull them in.
Is this just like a background app running on my phone? Or is it a major power draw?
No, this is a massive battery drainer. Some estimates say that a huge portion of your body's total energy expenditure just when you're sitting at rest is just running these pumps.
That is insane.
It is. But it has to happen. That separation creates an electrical gradient across the cell membrane. And without that gradient, your nerves can't fire, your muscles can't contract, your heart doesn't beat. If the pump stops, life stops.
Got it. Sodium out, potassium in. Okay. Now, within the capillaries, the tiny blood vessels, there's this constant battle, a push and a pull of fluid.
This is Starling's law, right?
It is. I really like the push and pull analogy for this.
Let's break that down. Who's doing the pushing?
Hydrostatic pressure is the push. That pressure comes from the heart pumping blood through the system. It physically pushes fluid out of the capillaries and into the tissues.
Like a garden hose with little holes in it?
Exactly. The water sprays out because of the pressure.
And the pull.
That's osmotic pressure, specifically what we call colloid oncotic pressure. This is generated by the big proteins, mainly albumin, that are floating around in your blood. They act like a sponge. They want to hold on to water, so they pull fluid back into the capillaries. So if I have heart failure, my hydrostatic push is way too high because all the pressure's backing up.
Correct. You push too much fluid out and you get edema. Your ankles swell up.
And what if I'm malnourished and I don't have enough protein?
Low albumin.
Then your sponge is too weak. You can't pull the fluid back in. It just leaks out into the tissues. And again, you get edema. It's a very delicate balance beam.
That makes so much sense. Okay, so that's the landscape. Now let's meet the management team. Who is running this whole show?
The MVP, without a doubt, is the kidneys.
The text calls them the workhorses.
They are absolutely incredible. Your kidneys filter about 180 liters of plasma every single day.
Wait, 180 liters. You just told me I only have about 3 or 4 liters of plasma in my whole body.
Exactly. That means your entire blood volume is being scrubbed clean and filtered roughly 40 to 50 times a day.
Wow. That really puts the workload into perspective.
And the amazing part is the recycling. They filter 180 liters, but we only pee out about 1 to 2 liters a day. They reabsorb 99% of what they filter. They are so efficient. So when we're monitoring a patient and we're looking at that tiny 1%, there's a very specific rule for nursing students to memorize about urine output.
The 1 LL rule.
Walk us through it.
The gold standard target for urine output is 1 LOL per kilogram of body weight per hour. So if you have a 70-kilogram patient, you want to see about 70 milliliters of urine in that Foley bag every hour.
Okay. But in the real world, hospital shifts get crazy. You might not be checking the bag every single hour on the dot. What is the absolute danger zone number?
The hard floor is 30 milliliters per hour.
30.
If you check that bag and there's only 20 milliliters or none, you stop what you were doing. That is a 5-alarm fire.
Why? Is it just that they're dehydrated?
It could be. But what it really means is the kidneys are shutting down. The perfusion is too low.
Yeah.
If the kidneys stop filtering, toxins build up, electrolytes go haywire, and you are spiraling toward multi-organ failure. 30 ml an hour is your canary in the coal mine.
Got it. But the kidneys don't work alone. They have supervisors, right? The hormonal trio.
Yes. Let's break them down. First up, you have ADH, antidiuretic hormone. I call this the tap water hormone.
Why tap water?
Because it tells the body to hold on to pure water. It doesn't care about salt. It just stops you from peeing out water. Your hypothalamus in your brain senses that your blood is getting a little too thick, too concentrated. And it tells the pituitary to release ADH.
So your brain literally tastes the blood, says, whoa, too salty, and releases ADH to keep water and dilute it.
Precisely. Then we have aldosterone.
The saltwater hormone.
Correct. This one's released by the adrenal cortex. It tells the kidneys to hold on to sodium. And because of osmosis, we know that where sodium goes, water follows. So you retain both salt and water. But there's a cost.
There's always a cost. Nothing is free in the body.
In order to keep that sodium, aldosterone has to kick something else out. And it kicks potassium out into the urine.
That is such a key interaction. High aldosterone means you are losing potassium.
Yes. And finally, the third member is the counterbalance. The natriuretic peptides, ANP and BNP.
These are the ones released by the heart itself.
Yes. When the heart muscle physically stretches because there's too much fluid volume, it releases these peptides, and they basically scream at the kidneys, dump everything, get rid of sodium, get rid of water. It's the body's own natural diuretic.
This brings us to the famous RAAS system, the renin-angiotensin-aldosterone system. I just remember these charts in school that looked like a spider web.
It is complicated, but it's so vital. This is the body's emergency response. This is what saves your life if you are bleeding out on the highway or severely dehydrated.
Let's walk through the cascade step by step.
Okay. It all starts with low blood flow to the kidneys. Maybe your BP is low, maybe you're losing blood. The kidneys panic. They release an enzyme called renin into the blood.
Okay, so renin is floating around. What does it do?
It finds a protein that's made by the liver called angiotensinogen, and it cuts it, turning it into angiotensin I.
Which is still inactive at this point. It's just a precursor.
Right. Then, as that blood flows through the lungs, an enzyme called ACE-angiotensin converting enzyme, it converts angiotensin I into angiotensin II.
And angiotensin II is the beast.
It is a massive vasoconstrictor. It clamps down hard on all your blood vessels to drive your blood pressure up immediately. And at the same time, it screams at the adrenal glands to release aldosterone to hold on to every drop of volume.
So it squeezes the pipes and fills the tank at the exact same time.
A perfect description. It's trying to repressurize the whole system.
Before we move on to the actual imbalances, we have to touch on the aging patient. The text specifically highlights gerontologic considerations. Why are older adults so vulnerable to this stuff?
They are probably the most vulnerable population for all of these issues, for a few reasons. First, older adults just physically have less body water to begin with. They have less muscle mass, which is what holds water, and more fat, which doesn't. So they have less of a reserve.
And what about their thirst mechanism?
It's significantly diminished. A healthy 20-year-old gets thirsty the second they need water. An 80-year-old can be profoundly dehydrated and simply not feel thirsty at all.
That is terrifying. And the assessment is tricky, too. The text warns us about the skin turgor trap.
Oh, yes. Please, if you're a student, do not check skin turgor on an elderly person's hand. Their skin has lost its elasticity just from age. It will tent, it'll stay up, even if they're perfectly hydrated. You'll get a false positive every time.
So where do we look instead?
Check the sternum or the forehead. Or even better, look at their tongue. A dehydrated tongue has these deep furrows in it, and it looks kind of small. Also, this is huge, check their mental status. Confusion is often the very first sign of dehydration in the elderly.
That's a great clinical pearl. Okay, let's talk about when the tank is either empty or full. Let's get into volume disturbances.
Let's start with hypovolemia, or fluid volume deficit, FVD.
Is this the same thing as dehydration? I feel like we use those terms interchangeably all the time.
In casual conversation, yeah, but
Yes.
clinically, no. And the text makes a really big deal about this. FVD is the loss of fluid and electrolytes in the same proportion. It's an isotonic loss.
Like what?
Think hemorrhage, or losing plasma from a big burn, or severe vomiting and diarrhea.
And dehydration, then?
Dehydration is specifically the loss of water alone, and you leave the sodium behind. So the blood becomes concentrated, it becomes hypernatremic.
How do we spot FVD in the labs? There's a specific ratio we need to know.
The BUN to creatinine ratio. Normally, it should be about 10 to 1, but if the BUN starts to rise, say, to 30 or 40, but the creatinine stays relatively normal, and that ratio jumps to greater than 20 to 1.
What does that tell you?
That is a classic sign of volume depletion. It means the kidneys are slowing down blood flow to conserve water, so the urea, the BUN, it piles up. But the kidney structure itself isn't damaged yet. It's a dry kidney, not a broken kidney.
And what does the patient look like physically?
They'll have a weak, rapid pulse. The heart is trying to compensate for the low volume by just beating faster. Orthostatic hypotension is key. If their systolic BP drops more than 20 points when they stand up, they are dry. Their skin will be cool and clammy because the body is shunting blood away from the skin to the vital organs.
Okay, now let's flip the script. Hypovolemia. Fluid volume excess.
This is usually caused by heart failure or kidney failure, or, frankly, by us by giving way too much IV fluid too fast, especially fluid with sodium in it.
And what are the telltale signs?
The big ones are distended jugular veins, what we call JVD, a bounding full pulse, and crucially, crackles in the lungs. That is literally the sound of fluid filling up the alveoli.
The text mentions a weight rule that it calls the gold standard for monitoring this.
Yes. Daily weights are so much more accurate than trying to track every sip of water and every pee. The rule is an acute weight gain of 1 kilogram, that's 2.2 pounds, equals 1 liter of retained fluid.
So if your heart failure patient gains 3 pounds overnight?
They did not eat 3 pounds of fat. That is physically impossible. They are retaining over a liter of fluid. That is an immediate red flag. You have to intervene before they literally drown in it.
Let's move to the chemical side of things. The electrolyte deep dive. We've got the big four: sodium, potassium, calcium, magnesium.
Let's start with sodium. I always call sodium the brain monitor.
Because its primary effect is on the central nervous system.
Exactly. Sodium dictates where water goes. So if you have hyponatremia low sodium, anything under 135, the water is going to rush into the cells to try and balance things out. The cells swell up.
And if brain cells swell up inside a skull that doesn't expand?
You get cerebral edema. That's confusion, headache, seizures, coma. It is incredibly dangerous.
But there's a huge safety alert here about treating it. You would think the answer is just, give them sodium fast.
Absolutely not. That is a massive trap. If you correct hyponatremia too quickly, you strip the myelin sheath right off the nerves in the brainstem.
And the myelin sheath is like the insulation on an electrical wire, right?
That's a perfect analogy. If you strip it, the nerves short circuit. It's a condition called osmotic demyelination syndrome. It can cause permanent brain damage, locked-in syndrome, or death. You have to go slow. Very, very slow.
What about the other way? Hypernatremia, high sodium.
The opposite happens. The cells shrink. Water gets pulled out of the brain cells and into the blood to try and dilute that high sodium. The signs are extreme thirst, a swollen, dry tongue, sticky mucous membranes, and eventually hallucinations.
Okay, that's sodium. Let's move on to potassium.
The heart monitor.
This is the one that keeps nurses up at night. That window is so narrow, 3.5 to 5.0 mLEQL.
That is it. You have 1.5 units of wiggle room. If you drop down to 2.5, you're in serious trouble. If you go up to 6.0, you're in serious trouble.
Let's talk hypokalemia first, low potassium.
This is often caused by diuretics like Lasix or by GI losses, a lot of diarrhea, a lot of gastric suction.
And what does that do to the heart?
It makes the heart muscle very irritable. You start to see ECG changes, flattened T waves, and these prominent U waves.
And there's a specific drug interaction mentioned here too, regarding digoxin.
Yes, this is critical. If a patient is on digoxin and their potassium level drops, they can become dig toxic very, very easily. The low potassium actually allows more digoxin to bind to the heart muscle, making it way more potent. It's a dangerous combination.
Now, let's talk about treatment, because there is a massive safety alert in the text on this one. It's in big, bold, red letters.
It's probably the cardinal rule of nursing. Never push potassium to 4.
And when we say push, we mean taking a syringe of the drug and injecting it directly and quickly into the IV line?
Correct. If you do that with potassium, you are essentially executing your patient.
That's a very heavy statement.
It's the reality of it. A high concentration of potassium delivered that rapidly to the heart will depolarize all the muscle cells and prevent them from repolarizing. The heart just stops. It seizes. This is literally the mechanism used in lethal injections for capital punishment.
Wow. Okay, so knowing that, how do we give it safely? Because patients need potassium replacements all the time.
It has to be diluted, always,
Really?
usually in a 100 milliliter bag of saline. And it must be given on an infusion pumping machine that controls the rate very strictly. You never trust gravity, and you never trust your hand to push it.
And there's a little catchy phrase to remember for when you should hold the dose.
No P, no K.
P as in P-E-E, urine.
Exactly. If the patient isn't peeing, no P, then you give no K.
Because if they aren't peeing, they have no way to get rid of it.
Precisely. The kidneys are the only real exit door for potassium in the body. If that door is welded shut like in acute kidney injury, and you keep pouring potassium into the system, the levels will skyrocket instantly. You'll send them into a fatal arrhythmia trying to fix the deficiency.
Which brings us nicely to hyperkalemia, high potassium.
This is a true medical emergency. It's often caused by kidney injury, certain medications like ACE inhibitors, or crushing injuries.
Why crush injuries? That seems random.
Because your cells are basically little bags of potassium. That's where most of it lives. If you get crushed in a car accident, all those muscle cells burst open and leak all their potassium out into the bloodstream at once.
And what does the ECG look like here?
The classic sign is peaked. narrow T waves. They look like a tall, sharp tent.
Yeah.
If it gets worse, the QRS complex widens, and you're heading straight for cardiac arrest.
So how do we fix it? The text lists a whole cocktail of emergency treatments.
It's a three-step approach, really. First, protect the heart. You give IV calcium gluconate. Now, calcium doesn't lower the potassium level, but it calms the cardiac muscle down so it doesn't stop beating. It stabilizes the membrane.
So that buys you time. What's step 2?
Hide the potassium. You give IV insulin and glucose together.
Why insulin?
Insulin acts like a key that opens the cell door to let glucose in, but it also drags potassium inside with it. So you're basically hiding the potassium from the blood by shoving it back into the cells. It's a temporary fix, but it can be life-saving.
And step 3?
Actually, remove it from the body. You can use a medication called Electrolyte, which binds to potassium in the gut so you poop it out. Or if it's really severe, the patient needs emergency dialysis to filter the blood manually.
All right. Next up on our list, calcium. You call this the muscle stabilizer.
Yeah, because calcium acts like a sedative for your muscles and nerves. It keeps them calm. So if you have hypocalcemia, low calcium, the muscles go a little crazy. They get very twitchy and irritable.
And this is where we see those two famous signs, Trousseau's and Schwostek's.
Classic nursing school exam questions right here. Schwostek's sign is when you tap the patient's cheek just in front of their ear. If their facial muscles on that side twitch and spasm, that's a positive sign.
And Trousseau's sign.
For that one, you inflate a blood pressure cuff on their arm above their systolic pressure. You leave it there for a few minutes. If their hand spasms into this flexed position, it kind of looks like a little claw. That is Trousseau's sign. It just shows how incredibly irritable the nerves are.
And the text mentions a specific type of surgery that often causes this.
Yes, thyroid surgery. The parathyroid glands, which control calcium, are 4 tiny little glands that sit right on the back of the thyroid. If they get accidentally nicked or removed during a thyroidectomy, calcium levels can just plummet.
What about high calcium? Hypercalcemia.
For that one, remember the mnemonic: bones, stones, and groans.
Okay, explain that.
Bones, because the calcium's leaching out of the bones, causing deep bone pain. Stones, because kidney stones form from all that excess calcium filtering through the urine. And groans, that's for constipation and abdominal pain, along with psychiatric groans like lethargy and confusion.
And the treatment involves just walking.
Believe it or not, yes. Weight-bearing exercise helps keep calcium in the bones. So fluids to flush the kidneys and mobility are the first line of defense.
And finally, let's hit magnesium, the ref.
I call it the ref because it manages the deep tendon reflexes.
So hypomagnesemia, low mag.
Low mag means the ref is asleep. The reflexes get hyperactive. You see tremors, tetany, even seizures. It looks a lot like low calcium, actually.
And who's the typical patient we see this in?
It's often associated with alcoholism. Alcohol causes the body to waste magnesium in the urine, and it also suppresses intake.
And hypermagnesemia.
The ref is blowing the whistle way too much. Everything slows down. The first sign is you lose your deep tendon reflexes.
So if I hit their knee with the little reflex hammer, nothing happens.
Exactly. And if it progresses, it slows down the diaphragm. You get respiratory depression, then cardiac arrest.
And there's a safety alert about IV magnesium, too.
Yes. It's a high-alert medication. You have to double-check the doses because an overdose will paralyze the breathing muscles. Very dangerous.
Okay, that covers the big 4. Let's wrap up with IV therapy and safety. We throw around these terms all the time. Isotonic, hypotonic, hypertonic. What do they actually mean for the patient's cells?
It's all about tonicity, which is just a fancy word for how the fluid affects cell size.
Start with isotonic, things like normal saline, lactated ringers.
Isotonic means it has the same concentration as your blood, so it stays where you put it in the veins. It doesn't really move into or out of the cells. We use it for volume expansion. If someone is in shock or dehydrated with low BP, you give isotonic fluid to fill up the tank.
But there's a catch with lactated ringers, right?
2 catches. Don't use it in kidney injury because it contains potassium. And don't use it in severe liver failure because the liver is what converts the lactate into bicarbonate. If the liver is broken, it can't do that, and the lactate just builds up and causes problems.
Okay. What about hypotonic fluids like 0.45% sodium chloride or half normal saline?
Hypotonic is more watery than blood. It's less concentrated. So if you put that in the vein, nature wants to balance it out. The fluid moves out of the vein and into the cells. It rehydrates the cells themselves.
And when do we use that?
For true cellular dehydration, like in diabetic ketoacidosis or DKA. But you have to be so careful. If you push too much fluid into the cells in the brain, you cause cerebral edema.
And finally, hypertonic, the scary one, like 3% saline.
This is very thick, very salty fluid. It does the opposite. It pulls water out of the cells and into the veins. We use this for severe life-threatening hyponatremia or to reduce brain swelling. But it is so high risk, you can overload the lungs with fluid in a heartbeat because you're pulling all that water into the vascular space. It's an ICU drug.
We can't talk about IVs without talking about complications at the site. We see infiltration and phlebitis on incident reports all the time. What is the difference?
It's a simple distinction. Infiltration is when the fluid is leaking out of the vein into the surrounding tissue. The skin will be cool to the touch, swollen and pale.
Because the IV catheter has slipped out of the vein.
Right. The fluid is going under the skin, not into the circulation. Phlebitis is inflammation of the vein itself, usually from the catheter irritating it or the medication being too harsh. The site will be red, warm, and you'll often see a red streak trekking up the arm along the vein.
And there's one last rare but deadly complication mentioned: air embolism.
Yes. This is terrifying. If a significant amount of air gets into the IV line, maybe the tubing disconnected, it can travel to the heart and literally block blood from getting to the lungs.
What does that sound like?
The classic textbook sign is a mill wheel, murmur, a loud churning sound over the heart as the blood and air mix.
And the immediate intervention. This is something you have to do in seconds, not minutes.
Immediately, you turn the patient onto their left side and put them in the Trendelenburg position, head down, feet up.
Why left side, head down?
It's pure physics. You want to trap that air bubble in the apex of the right ventricle, away from the pulmonary artery where it would cause a blockage. If you can trap it there, the heart can still pump blood underneath the bubble, and it buys you time for a doctor to come and try to aspirate the air out.
If they sit up, the bubble goes to the lungs.
And they die. It's that critical.
That is vivid. Okay, let's try to unpack this whole deep dive. We have covered a massive amount of ground here.
We really have. We've gone from the microscopic sodium pump all the way up to macroscopic fluid overload.
What's the synthesis? How do we put all these pieces together in our minds?
I think it's about realizing that these systems are all completely interlocked. You can't just fix sodium without thinking about water. You can't fix water without thinking about the kidneys. The kidneys manage the sodium, which moves the water, which affects the blood pressure, which then triggers the heart and the RAAS system. It is one continuous, beautiful, complicated loop.
And for the nursing student listening to this, this isn't just about passing a test on Chapter 10.
Not at all. It's about patient safety. When you see a patient who is suddenly confused, don't just assume it's their dementia acting up. Check their sodium.
Yeah.
When you see a weird-looking T wave on the monitor, check their potassium. The labs and the physical signs, they tell a story. You just have to learn the language.
I want to leave our listeners with one final thought from the text. It briefly mentions something called insensible loss.
Ah, yes. The invisible tide.
We lose about 300 to 500 milliliters of fluid every single day just by breathing and through our skin, even without visible sweat.
That's right. Even if your patient is NPO, not drinking a drop, and sitting perfectly still in bed, they're evaporating. The river is constantly flowing out of us invisibly. As a nurse, you aren't just watching monitors or hanging IV bags. You are managing an invisible tide that never, ever stops.
That is a really powerful image to end on. To all the nursing students out there, take these dry facts, pun intended, and apply them. Look at your next patient and try to see the balance or the imbalance.
Stay curious and keep those electrolytes balanced.
Thanks for listening to The Deep Dive. We'll see you next time.